Welcome to another of our discussions with HSS leaders and participants in the hospital's response to the COVID-19 crisis. The series entitled The Power of Pivoting, Managing Through Crisis. I'm Dr. Ronald McKenzie, an internist and rheumatologist at Special Surgery and the moderator of this series. So today we are featuring the efforts of our medical staff, who I think it's fair to say, along with the anesthesiologist, did much of the heavy lifting over the last 2 months. Here present are Doctors Linda Russell, usually the Director of Perioperative Services and the Osteoporosis and Metabolic Bone Health Center, Veronica Fusco, a hospitalist physician at Special Surgery, and Kimberly Showalter, a clinical fellow in our rheumatology division, all of whom were truly frontline contributors to the HSS coronavirus effort. So welcome to all of you. Now I want to begin with Linda, who certainly from an administrative standpoint served in a number of important capacities. And Linda, I'd like you to tell us what you've been up to.
Sure. It was a very interesting time for us. We had to take all of our internists and hospitalists and go from being a perioperative division to enabling us all to take care of very ill medical patients. And what we did, we decided to take our physicians, our internists, our hospitalists, our rheumatologists, and some of our primary medicine colleagues, and we developed a call system of 3 days on and 3 days off to take care of the patients. We developed 14 teams that worked days, nights, and swing shifts, and we really had to manage patients that most of the staff are not comfortable managing, very ill medical patients and COVID positive patients. And what I did, I worked with 3 hospitals in New York City, Weill, Cornell, Lower Manhattan, and NYP Queens. And I work with the hospitalists and internists at those facilities to try to bring patients from those facilities to HSS to help with their overflow. And the tricky part of it was we tried to bring patients here that were hopefully improving. Almost all the patients were COVID positive, and we were all trying to learn together when patients would start to recover. And what we've learned is it can be a little tricky deciding when patients are recovering. You think they're getting better, and all of a sudden they deteriorate and they may have to be intubated. So for nearly 5 weeks, every single day, 24/7, I worked with nursing leadership at HSS and the medical physicians at these outside hospitals to decide who we could transfer to HSS. And at its peak, we were bringing in maybe 20 patients a day. And it was a lot for the staff, for all the physicians, for all the nurses, the physical therapists. Every single department had to change how they were caring for patients so that we could care for this new complex set of patients. And it also was tricky because the patients could have no visitors. So while you were caring for the patients, you really felt like you had to really take care of them, the whole person, because they really weren't having any visitors and they were moving from hospital to hospital. So it also was very, difficult for the patients. I think it was a difficult time because I just didn't want the patients to come to HSS, deteriorate, and have to be intubated. I was trying to not let that happen. And in some cases, unfortunately, it did happen. Patients, as I mentioned, seemingly are doing very well. And then their oxygenation requirements would increase and they'd have to be intubated. And we learned with these patients, when they ambulated, their oxygen requirements went up tremendously. So it was really a work in progress. there were a lot of other physicians in the hospital that volunteered a little more on an ad hoc basis to help us. Some of the radiology attendings and some of the radiology fellows and some of the orthopedic fellows and residents would help more on an ad hoc basis. And we welcomed everybody's help because there was a lot of work admitting all the patients and then rounding on them on a regular basis. I don't think any of us will ever forget this time. I feel like we all tried very hard to do our part in New York City and to help the community. And I think we did do that. And I know my colleagues at Cornell, Lower Manhattan, and NYP Queens were very, very grateful when we had a conference call every day. And I would say, okay, we'll take that patient. If the patient was at Weill Cornell, they could come across the bridge, which connects our two hospitals. The other hospitals, we had to get ambulances to bring the patients to HSS. That in itself was difficult because there weren't many ambulances free during the height of the pandemic because so many ambulances were out in the community bringing people to hospitals. We had to try and get access to all the electronic medical records at these outside hospitals so that once the patient came to HSS, our staff could go into the electronic medical record and make sure they knew what had happened to the patients at the other hospitals so that we could care for them. We could know what their medications were. We could be privy to their social situations so that we could help with discharge. It was a very interesting time. I think medicine and nursing really worked together, and it was a good feeling to be able to care for all the patients together.
Linda, thank you very much for that commentary. And I'd like to turn now to Veronica and Kimberly. The audience, has heard both in this series and also just simply in the lay press a lot about the pulmonary problems experienced by these patients. But for those who did not develop the pneumonia associated with COVID, who did not ultimately need a ventilator, what did these patients look like? What conditions did they have? What were you treating? And actually an additional comment, and Linda could make this as well, as Linda, you made reference that you couldn't predict the pathway of recovery for these patients. What about the capacity to predict their deterioration, which, as we know, can occur so acutely and in such a threatening way? So Veronica, maybe you could just begin addressing some of those questions for us.
Well, these patients actually, we took care of the non-ventilated hypoxemic patients. They were all in acute respiratory failure. They require 5 to 6 liters of oxygen. Some of them has to go to non-rebreather. So most of them, I would say actually all of them had chest X-ray with pneumonia, some kind of infiltrates. So at the beginning it was extremely challenging since we didn't know anything about these patients. So some of these patients came with ceftriaxone and azithromycin, since at that time the test was not really as fast as this right now. We were waiting for 2 or 3 days. So then we follow with the Plaquenil, right? Once we had the results and all of them were certainly COVID positive, we start with the Plaquenil. What it was different is that patients with pneumonia does not require that much oxygen when we talk about intermediate floor care. They are hypoxemic, but maybe on the 88s, 90s, these patients were low to 70s. And the big difference to me was that some of these patients tolerate this very well. They will be on the phone, they will be texting, and this was such a slow process and very slow progress. I mean, every day there was like a minimal improvement. So they stayed with us for month and a half. And as Dr. Russell pointed out, obviously every time that they would try to even go to the bathroom, with minimal mobilization, they would become really hypoxic. So, and to me as a physician, the challenge was that I didn't know how to make this better. We tried to read every day, to update ourselves. We discussed with colleagues, but at the beginning was the feeling of we're lost. And we also recognized that the patients were in a room and they were so lonely and confused, and we tried to encourage them to speak with their family members, and but it was very challenging for them as well.
So that the term hypoxemia is a reference to the oxygen level that a patient has, and Dr. Fusco has referenced levels in the 80s and maybe upper 70s, and just for the audience's knowledge, a normal oxygen level would be 97 or 98%. So these were very, very low levels of oxygen, indicating that there was considerable impairment in lung function. So Kim, perhaps you could tell us a little bit about your perspectives of the problems that these patients were facing and the challenges you faced looking after them.
Absolutely. So my role during the few weeks of working was mostly to admit patients as they were being transferred in a swing shift that was in admissions. And so patients were at a really vulnerable state. They were getting transferred to a new hospital instead of going home. And it felt like, I think to many of them, that they were even further away from getting home. And it was difficult. And the patients were very sick, and they had a lot of oxygen needs. And, they were more or less comfortable. But we all knew that at any moment they could become much more sick. And the patients knew that too. And, we called them. So we wanted to take our time and spend a long time talking to the patient and being, as supportive as possible. So many times, especially when we knew the conversation would be quite long on their transfer, we would call them from outside the room and really take our time, hear their story, understand their history, offer as much support as possible, knowing that, when we walked in the room with, face masks and, shields and goggles and, all of the PPE we used, it was, just harder to have that personal conversation, which, we felt like we could really achieve sometimes best on the phone. And, the patients were worried. They were worried about their families. I had many patients whose family members had already passed away, which was, very, very sad and difficult. They were worried that they couldn't see their families. We used, iPads and FaceTime so that people could connect and see their families as they were sick. They were worried about infecting us. I had one patient after a long phone call tell me that he felt like we were pretty good, and that, that I don't need to come in the room because he doesn't want to put me at risk. And of course we went in and spent time to examine him and make sure he was doing okay, say hello in person. But I think that the concerns of the patients were really broad. And I think, many patients knew that their condition could change at any moment. And many patients knew that we didn't know exactly the best way to treat and which medications worked, because no one was a coronavirus expert yet.
So, Kim, you raise an interesting point, and Veronica could perhaps respond to this too, but one of the somewhat unique features of this illness, of course, was that it imposed a relatively substantial risk on the caregiver. And while we have some other diseases that do that, nothing on the order of magnitude that the coronavirus presented. So I'm just wondering a little bit about how you responded to that apprehension. Did you feel, for instance, that the patient protective equipment was plentiful enough? Were there worries about that?
So regarding the PPE, I felt like there was definitely adequate supplies as we were working, which I was very grateful for. I think that there was a lot of nerves around the process and the steps, putting it on, taking each piece off. And to that regard, I felt like everyone worked so well as a team. The first day I had never done it in the team room, practicing with the other hospitalists, each step, and having someone watch you and remind you of different things that you might be doing, or times that, you need to recall and remember to, take certain precautions at each step. And, I remember the first time going in and out of a patient's room, feeling really confident as I walked towards the door that everything went well, and I felt really safe, and getting towards the door and having a moment of sort of mini panic of, wait, what's the next step? And immediately saw that on the door there were laminated instructions reminding you of each step and what to do, and I felt really reassured. And as I walked out, the patient's nurse being there to help me with all of the steps as I was finishing the process was really supportive and reassuring. And while, that day I was the one, learning and practicing, it was like the very next day that I was in the team room watching one of my colleagues who was learning for the first time as well, and supporting each other. And I think that the teamwork and the patience that everybody had towards helping each other know how to really protect yourself was really important and helpful.
So I suppose that apprehension eased a little bit over time, but did you find eventually that you might have a tendency to be a little bit loose about it, or did the concern was of a sufficient magnitude that just didn't happen?
I think the concern of infection kept everyone vigilant. I think that there was always, the reminder that if you, touch some part of your body, you can always go and wash with soap and water. That kind of helped you become more calm and know that there was always the, chance to, there's no, you could undo, any parts of those process, as long as you weren't touching your face. And I think that when the nervousness improved, I think that the process became really smooth and effective. And I think that as everyone was calmly putting on and taking off their PPE together, the process went more smoothly, I think.
I just was trying to get the sense from people who were participating on the front line about how the concern about the infectiousness of this to the caregiver, how that played out relative to your function as a physician.
Certainly, we were very concerned at the beginning. Like I said, we didn't know much. So we knew that the donning and the doffing was like critical. So we really practiced with the nurses and the medical staff before receiving the first patients. We created cleaning stations outside the rooms and near the sinks with disinfectants and alcohol. That was actually, it's actually a very good question, since we were all concerned about getting infected and going back home to our families. But we always had the adequate PPE.
So I'm going to just bring this to a close with two things. But the first is, it's to Kim. So Kim, tell us a little bit about the impact this experience on your education. I mean, you're in, I think finishing, is it the second year of your fellowship? Third year, sorry. It goes by. And obviously this isn't exactly what you had in mind for its finale. So can you tell us a little bit about the impact this has had?
Right. So as far as fellowship and, having this be the end of my training, I think that there are two parts to that answer. The first is that rheumatology education continued in platforms that I didn't know everyone could all come together and use. Slack and Skype and Zoom. We had multiple meetings, with all of the fellows, faculty. We started expanding case conferences and had new attendings join that usually perhaps were in clinic or other obligations remotely. And, I felt like the community of education was maintained. There were many resources through HSS, through the ACR, that kind of kept the learning for rheumatology patients ongoing and effective. I think that we started doing telemedicine, which I, never anticipated that would be part of my fellowship. I think training for telehealth is so important. I think that that's going to be a big part of our future, even more so, now and in years to come. So I think that was an amazing opportunity to have that as part of my training. And then I think that the other answer is that learning and being in training is more than just, the rheumatology medications and caring for specific conditions. It's the kind of art and uncertainty, which in rheumatology we experience so much of. And I feel like everyone felt it together caring for patients with COVID. Knowing that we're using medications off label, we aren't sure exactly which ones are going to be proven effective, and the patients know it, and we all kind of work and learn together. And I feel like that experience taught me so much, from the perspective of a fellow in training, and kind of how I'd like to be as an attending and through the rest of my career.
So actually, this is a bit of an aside, but you just made me think of something in that response. And perhaps you or Veronica could address this. So having looked after these patients now intensively for the last 2 months, do you have any sense that any of the medications that we use to treat these patients worked?
Kim, you go first.
I don't know. I'm not sure what worked. I know that time worked. I know that oxygen worked. I know that support and, the supportive care that we always give worked. Patients were coming in on different medications. I admitted patients on, biologic medications like anakinra that they'd been started at Cornell. I admitted patients who received antibiotics and Plaquenil. People were mostly, heading in the correct direction. I don't think my experience, I could say there was anything that, you gave and the next day you saw the patient as a completely new person. I think each of the things we did, seemed helpful to kind of get the patients through, in my experience.
I just want to add that since we took care of these patients since the beginning, you don't really know, like Kim said, what really worked or not, since patients had antibiotics, Plaquenil, tocilizumab, ivermectin. I have patients that also received the convalescent plasma. So at this point, you don't know if they really turned because that was their own physiology, or if any of these medications work. So that's the part that to me is very confusing. And I'm actually looking forward to see more of these patients if we have to, and start, one medication at a time and see if we can actually see if any of them actually work. Because at this point, it's actually most of the patients got most of the medications. It was very difficult to cohort these patients and say, okay, I have this brand new patient and I'm going to start giving anakinra, or I'm going to start giving the remdesivir. So as Kim said, oxygen worked. There are also some patients that are doing very well on the steroids IV. So it will be very interesting to actually start now, brand new.
Well, listen, I think we can conclude here. I may have Linda just wrap it up a little bit. I'm sure that you're all relieved that we're on now the back end of this experience, which I'm sure was professionally, if not life-defining for all of you. Any final words, Linda?
One positive thing that came from all of this is that we have a much better relationship with the other hospitals in the city, especially Weill Cornell. We took patients with appendicitis to HSS, and we cared for them here with the surgeons because they were COVID negative, and the surgeons didn't want their patients exposed to the COVID positive floors at NYP. So the relationship we have now with all the departments at Weill Cornell is wonderful. And I think that's one of the really positive things that came out of all of this.
Well, listen, thank you all very much for your time and your comments. It was a really very fascinating perspective on this experience to which you contributed so significantly.